Hello, future nurses. This is Professor Hale. In this video, I will be focusing on nursing care of patients in shock. This is Chapter 9 in your medical surgical textbook. Here are the learning outcomes. So I do know that you have a good foundation and knowledge and understanding of shock and the various types, and this is probably you covered in your cardiovascular system with Professor Charbonneau. So shock is defined as inadequate tissue perfusion. So shock is critical condition where the body has decreased tissue perfusion and eventually leading to organ failure and ultimately death if it's not treated immediately. So going on to the pathophysiology of shock, tissue perfusion of blood pressure are maintained by three mechanisms. The first is adequate blood volume. The second is effective cardiac pump. Third is effective blood vessels. So that is the blood is able to compensate for a problem in one mechanism. So it does so by making changes in one or both of other mechanisms. Shock occurs when the compensatory mechanisms fail to maintain the blood pressure, and this can be leading to poor tissue perfusion. Causes of shock include inadequate cardiac output, caused by heart failure, hemorrhage, or sudden decrease in peripheral vascular resistance, and due to anaphylaxis, which is a life-threatening allergic reaction. Sepsis, which is a life-threatening condition caused by the body's response to an infection resulting in organ dysfunction, or neurological or alterations. Metabolic and hemodynamic changes in shock. So when the blood pressure falls, the sympathetic nervous system is activated. The compensatory mechanisms then begin, and this is when you're going to see the epinephrine and norepinephrine, which are released from the adrenal medulla. And this causes the heart to beat faster and stronger to increase cardiac output. So the signs and symptoms that you're going to see are tachycardia, tachypnea, increased blood glucose, blood shunted away from intestines, kidneys, and skin, vasoconstriction, and retention of sodium and water. So tachycardia is a compensatory mechanism that is usually the first sign of shock that you're going to see. Sustained tachycardia is a signal that the patient's condition is changing. In older patients, they can't tolerate tachycardia for too long. So this is when you want to report tachycardia to the registered nurse or the healthcare provider. You want to consider the cause of increased heart rate, tachycardia, which is, for example, a surgical patient who develops tachycardia may be hemorrhaging. So you want to check for bleeding, apply direct pressure to an area of hemorrhage if it's external. And with internal hemorrhaging, there may not be visible bleeding, but vital signs may be the only sign. So that is when you want to take action. So prolonged shock causes extensive damage to the organs, and this is because the inadequate blood flow results in tissue ischemia and injury throughout the body. Early shock, blood is shunted away from the kidneys to save fluid. This helps preserve blood pressure to provide oxygen to vital organs. And the kidneys can tolerate reduced blood flow for about an hour. Then the kidney cell begins to die from the lack of oxygen and nutrients. Acute kidney injury can result from this. And when the myocardium, which is the middle muscle layer of the heart wall, receives inadequate oxygenation, pumping action and cardiac output decreases and shock worsens. Acidosis, toxins released into the bloodstream from its ischemic tissues or ischemia-induced arrhythmias, and this is abnormal heart rhythm, and it further reduces the pumping ability of the heart. So if the brain is deprived of blood flow for more than 4 minutes, brain cells die from the lack of oxygen and glucose. So then there's ultimately going to brain death occurs from prolonged shock. Organs and gastrointestinal systems, they can be injured early in shock because of the inadequate circulation to the intestines, and it injures the mucosa. Paralytic ileus, which is intestine paralysis, can also occur. So if gastrointestinal bacteria and endotoxins move from the bowel into the circulation, toxemia can result. And last, liver, it can be injured by ischemia. So the liver function is affected by this injury. Elevated serum levels of ammonia, bilirubin, and liver enzymes, and decreased production of plasma proteins can occur. The immune system is weakened by shock, and this is leaving the body vulnerable to infection. So if the liver has been damaged, it cannot assist an immune system in providing defense. Complications of shock include acute respiratory distress syndrome, disseminated intravascular coagulation, multiple organ dysfunction syndrome. So to understand what disseminated intravascular coagulation means, you want to define like each of the words. So disseminated means scattered or widespread. Intravascular means intra, which is inside, vascular, which is a vessel, and coagulation, which is clotting. So when you put all of them together, the definitions tell you that DIC is a scattered widespread clotting, which is inside the vessel. So that's what that means. The classification, there are 4 types of shock that are classified by their cardiovascular characteristics. We have the hypovolemic shock, which is caused by a decrease in circulation blood volume. Cardiogenic shock, which is caused by cardiac pump failure. Obstructive shock, which is caused by a blockage of blood flow in the cardiovascular circuit outside the heart. And distributive shock, which is caused by an excessive dilation of the venules in the arterioles. The classic sign in all forms of shock is decrease in blood pressure below the level of need to provide a sufficient blood flow in the tissue for adequate oxygenation. So we're going to continue on. We're going to first begin with hypovolemic shock, which could be caused by dehydration, internal or external hemorrhage, fluid loss from burns, vomiting, or diarrhea, or loss of intravascular fluid into the interstitial space of sepsis, or trauma, which is physical injury caused by an external force. Heat exhaustion or heat stroke can also cause hypovolemic shock from excessive water loss through sweating. Signs and symptoms that you're going to see initially are tachycardia, cool, clammy skin, tachypnea, flat, non-distended peripheral veins, and a decreased jugular vein circumference. And then you're going to also see when tachycardia, it may be the only symptom. So kind of give you a big idea of blood loss. Usually, if there's a blood loss, then 15%, which is blood loss of 750 mLs, you'll see pretty much tachycardia with that, and it may be the only symptom. But at 20 to 25% blood loss, tachycardia and mild to moderate hypotension are present, and a loss of 40% or greater, which could be equivalent to 2,000 mLs, you'll see all signs and symptoms of shock. Volume loss alone, it may not be the only contributing factor to hypovolemic shock. Usually, you want to consider the patient's age, health status, and time frame for the fluid loss to be also factors. A little tip, I know people say Trendelenburg position in which is the body is supine with the feet raised higher than the head, was formerly used to increase cardiac output and hypovolemic shock. However, there is research that has shown that it's not helpful in improving cardiac output for patients in shock, and it can have a profound negative effect. So although you might still see this position being used, remember that evidence-based practice procedures is best for patient outcomes. And with hypovolemic shock, you want to, treatments are usually fluid replacement. You want to give them fluid therapy as ordered and monitor vital signs as well. So cardiogenic shock, it is a decreased cardiac output. Causes are usually MI, dysrhythmias, and pump failure. You're going to see pulmonary edema that results, and that can differentiate cardiogenic shock from other shocks. Also be mindful of fluid therapy. It actually, when you're giving fluid, it actually increases the mortality as they're already at fluid overload. So you don't want to give them more fluid on top of that. So you would be mindful of that. Other causes for traumatic injury to the heart that can cause cardiogenic shock or myocarditis, which is inflammation of the heart, cardiomyopathy, heart valve defects, endocarditis, or arrhythmias. And then we have obstructive shock when there's a blockage of the blood flow outside the heart. Causes are pericardial tamponade, tension pneumothorax, acute pulmonary hypertension, and then another good classic sign, you'll see a jugular vein distension. Distributive shock occurs when there's a peripheral vascular resistance is lost because of massive vasodilation. In hypovolemic shock, there is an actual loss of blood. But in distributive shock, there's no loss of fluid volume, rather than the body's fluid distribution is altered within the body. So there's 3 forms of distributive shock, which are anaphylactic, septic, and neurogenic. So anaphylactic shock is the most severe type of distributive shock, and it is extreme hypersensitivity reaction to an antigen, which are insect stings, medication, peanuts, antibiotics, anesthetic, contrast dye, or blood product. Most common is usually food allergies like peanut allergy or shellfish or shrimp. You want to educate the patient to carry an EpiPen with them and how to use that, correct use, and when to seek medical attention or emergent care. They should also educate them to carry medical alert information of their anaphylactic allergies, of their allergies and the reaction. Signs and symptoms of anaphylactic shock include tachycardia, tachypnea. You'll hear wheezing in the lung sounds, hypotension, cyanosis or oliguria. Sometimes they'll have altered mental status. They can also have urticaria, pruritus, angioedema, laryngeal edema, severe bronchospasms. And if they're conscious, they can be extremely apprehensive and risk. So when we see patients with a septic shock, it's usually due to most common sites of that cause septic shock are gastrointestinal, lungs, skin, or urinary tract. And those are the common sites of infection that can lead to sepsis and sepsis shock. When they come into the ER, they have hypotension, and it's due to extreme hypoperfusion, and it can lead to multi-organ failure, kidney failure. They are high risk for death. What factors that place them in a higher risk of this is with age, 65 and older, chronic illnesses, weakened immune system, severe burns, or other critical illnesses. So treatment, when somebody comes in with septic shock, initially, you're going to get some 2 large bore IVs in them. You're going to get IV access. You're going to administer fluids, 30 ml per kilogram. And there's a calculation so once they max out on the fluids, they want to consider vasopressors. They will be admitted to intensive care unit. Sometimes they will be intubated to protect their airway when when they become severely hypoperfusion, when they're not compensating. So they will be monitored very closely in the ICU. Immediately in the ER, they will get blood cultures, they'll get a urine culture, and they will do that prior to administering IV antibiotics. So they'll do a broad spectrum antibiotic. Usually they'll use 2 different ones to cover that within the 3 hours of recognition of sepsis. So when you go into the ER, and if you're ever going into the ER, just look, every facility and their facility policies are different, but they always have a sepsis protocol. So they follow that protocol to the T, and they get all this stuff within a period of time. And it's because quick treatment and management increases the more of increases the outcome of a patient. So it becomes more optimal with a quick, swift treatment of sepsis. Neurogenic shock, it's pretty rare, but it occurs due to nervous system injury dysfunction that causes extensive dilation in peripheral blood vessels. And causes include spinal cord injury, general anesthesia, fever, metabolic disturbances, and brain contusions and concussions. Signs and symptoms include hypotension, altered mental status, and during the early phases, bradycardia and warm, dry skin. And as the shock progresses, tachycardia and cool, clammy skin develops. Here are the more primary nursing diagnoses to focus on for any shock and infected tissue perfusion. You need the nursing care and management of that for that diagnosis, decreased cardiac output, and deficient knowledge. An assessment of patient in shock includes, you want to recognize the signs and symptoms, which include tachycardia, tachypnea, hypotension, oliguria, cyanosis, and altered mental status, and I know you all know this. Laboratory tests that are most likely to be obtained with shock are arterial blood gases, blood chemistries, blood typing cross and match, because there's hemorrhage, internal or external, cardiac isoenzymes, complete blood count, partial thromboplastin time, and a prothrombin time, serum lactate, which is will identify sepsis, and that would be equal or more than 4 with the lab value there, and serum osmolarity, and urinalysis. Imaging will include chest X-ray, CTs, CAT scans, echocardiogram, and spinal X-ray. And then monitoring, you want to have them on an electrocardiogram, arterial pressure, hemodynamic monitoring. So those are the pretty much the takeaway in the care and management, and for you to focus on. You already know this information. You already know the signs and symptoms. I know this because you guys created a sim, and it was amazing. Here are the therapeutic measures and nursing care for shock. Maintain airway. Like I said, monitor ABGs. Provide cardiovascular support to maintain systolic blood pressure of 90 or greater. Dopamine, that's with a medication with a vasopressor to treat that, to increase that blood pressure if needed. Maintain circulatory volume by fluids, blood infusions, transfusions, plasma expanders. Increase tissue perfusion, which with pressors, epi or norepi. Indwelling catheter to monitor hourly outputs, and that's 30 mLs per hour. And administer diuretics, diureses, which are furosemide, Lasix. Control bleeding, internal or surgery, or external. And external with pressure dressing. You want to treat acidosis. And BiPAPs are used to correct the CO2 levels. Treat cause and identify source of infection. And this is with blood lab draws like CBC, blood cultures, urine cultures, antibiotics, fluids, low doses steroids, and you want to keep them warm. Monitor frequent vital signs, pain management, and pressure reduction. And that is the takeaway with that. The pathophysiology and etiology, it's good to know. Don't go crazy on that. It's just pretty much the signs and symptoms to recognize that and what's going to be treated. And I believe you guys already know all this. This is just an overview of shock for you guys. And that is it for this video.